Imagine this, a routine infection, maybe a cough that just won't quit, or a cut that looks a bit iffy. You might not think much of it, maybe even shrug it off. But then things take this really terrifying turn, almost instantly. Suddenly, your body's own defense system, your immune army, it just goes completely rogue, stops fighting the invader, and actually starts attacking you. This isn't some medical drama plot. It's the devastating reality of sepsis. People often call it the silent killer because it can be so sneaky, yet, well, so brutally fast.
Yeah, it really demands your full attention. As you start your medical journey, sepsis is honestly one of the most critical conditions you'll encounter. Your ability to understand it, spot it, and crucially act on it. Well, that can genuinely be the difference. The difference between a patient going home or facing really severe life-altering complications. Or, worse.
Absolutely. So welcome to the deep dive. Today we're cutting through all the complexity to really arm you as a future medical professional with the core knowledge you need, not just to know about sepsis, but to hopefully truly understand it, retain it, recall it when it matters. We've gone through a lot of reliable medical sources, pulled out the key insights, and we're trying to distill these complex ideas into something, well, practical and actionable. Think of this as like your foundational toolkit for saving lives.
Exactly. It's about building that mental framework, that ability to think critically when the stakes are just incredibly high.
Right. So our journey today, we'll start by defining what sepsis actually is. Then we'll look at the common culprits, the infections that trigger it. We'll peel back the layers on the pathophysiology, what's going wrong inside the body. It gets pretty chaotic. Then how to spot the signs, which can be subtle. And most importantly, how to act decisively. Because with sepsis, every single minute counts. Okay, so to really fight an enemy like this, we need to understand it first. Beyond the headlines, beyond the alarms, what is sepsis, fundamentally? Our sources give us this pretty powerful definition. Sepsis is a life-threatening organ dysfunction due to an infecting pathogen and a dysregulated host response to infection. Now that phrase, dysregulated host response, that really jumps out at me. It sounds like the fight isn't just against the bug, it's against our own body's reaction too. Could you maybe expand on why that part is so central?
Oh, absolutely. That's the absolute key. It's not just the infection itself. It's how your body essentially overreacts, causing damage system-wide. Think of your immune system, right?
Yeah.
It's like a highly trained bodyguard. Normally it protects you. But in sepsis, that bodyguard doesn't just neutralize the threat. It goes completely rogue, starts causing massive collateral damage, turning its weapons on the very organs it's supposed to protect. And this leads us nicely into understanding the sepsis spectrum. It's a progression.
A progression, right. That's crucial, isn't it? It often starts small, relatively speaking. Microbes, usually bacteria, they get in, breach our barriers, and bacteraemia, basically, bacteria in the bloodstream. And from there, the body kicks off what's called SIRS, Systemic Inflammatory Response Syndrome.
Yes, SIRS. Think of it as the body's generic fire alarm. It's a widespread inflammatory response. But, and this is important, it's not always triggered by infection. Major trauma, severe burns, even pancreatitis or heart attack can set off SIRS. To meet the criteria for SIRS, a patient needs 2 or more of these specific signs. Things like an abnormal body temperature, either too high or too low, a fast heart rate, over 90 beats per minute, rapid breathing that's over 20 breaths a minute, or maybe a low PaCO2 on a blood gas, which indicates they're blowing off too much CO2 from breathing fast. Or finally, an abnormal white blood cell count could be too high, could be too low, or showing a lot of immature cells called bands.
Okay, that leads to a really important question for you, our listener, to think about. Can a patient actually meet these SIRS criteria without having sepsis? Just keep that question ticking over in the back of your mind as we go deeper.
Yeah, it's a critical point because the moment SIRS becomes sepsis is when that whole inflammatory storm is specifically triggered by an infection. That's the link. Unfortunately, it doesn't always stop there. It can get worse.
Right. If that dysregulated response keeps escalating, we enter the territory of severe sepsis. And that's defined as sepsis plus signs of at least one organ beginning to fail. So we're talking about things like dangerously low blood pressure, what we call hypotension, or maybe lung injury causing difficulty breathing, problems with blood clotting showing up, maybe low platelets, which is thrombocytopenia, or signs the kidneys are struggling, like putting out very little urine, liver dysfunction too, or a high lactate level.
And then the most severe stage, with the highest mortality, sadly, is septic shock. This is severe sepsis, but with persistent, dangerously low blood pressure despite giving the patient lots of intravenous fluids. We call this hemodynamic instability. At this point, the body's attempts to compensate are just failing. They're overwhelmed. That bodyguard gone rogue analogy we use, this is where it's truly running rampant, and the damage is incredibly difficult to contain.
That breakdown, thinking of it as a spectrum and using that bodyguard analogy,
Yeah.
that really helps cement the core idea, I think. Okay, so let's talk about those initial invaders, the culprits. We know fungi and viruses can cause sepsis, but the vast majority of cases, they're bacterial, right?
Absolutely, the overwhelming majority. And while the list of potential bacteria can seem, well, daunting, a really key insight from the sources is that the site of the initial infection is often your best clue. Knowing the usual suspects for, say, a lung infection versus a urinary tract infection helps narrow things down and guides that crucial early treatment. For example, with respiratory infections, you're often thinking about pneumococcus or maybe Haemophilus influenza, even Staphylococcus aureus.
And for UTIs, urinary tract infections, it's commonly things like E. coli, maybe Klebsiella, Enterococci, Proteus, or Pseudomonas. Skin infections often involve Strep pyogenes or Staph aureus. And if you suspect meningitis, you'd think about meningococcus, Haemophilus, pneumococcus. For surgical infections in the gut, it's often gram-negatives like E. coli again, and anaerobes too.
Yeah, and we always have to maintain that high index of suspicion for certain groups. People who are immunocompromised, maybe due to chemotherapy, steroids, or other treatments. Also, babies and young children, the elderly, they're particularly vulnerable. Patients with communication difficulties, pregnant women, post-operative patients, anyone with recent trauma. Those with pre-existing conditions like diabetes or sickle cell disease, and definitely anyone with indwelling lines or catheters or IV drug users. These groups can harbor different, sometimes more resistant organisms. And what's particularly interesting is that gram-negative bacteria like the E. coli you mentioned seem to be especially notorious for triggering really severe sepsis.
Okay, why is that? Why do gram-negatives stand out? Is there something specific about them that makes them like superchargers for this dysregulated response?
There is, actually. It's a component in their outer membrane called lipopolysaccharide, or LPS. You might also hear it called endotoxin. LPS acts like a massive, potent alarm bell for our immune system. It strongly activates key immune cells like macrophages and natural killer cells, really amplifying the immune response much faster and, frankly, more aggressively than many gram-positive bacteria. It's sort of like throwing gasoline on that inflammatory fire, pushing that dysregulated response into dangerous overdrive.
So it's not just that bacteria are present, but the type of bacteria and its specific bits and pieces can really dictate how severe things get. But here is a really challenging point for clinicians, isn't it? In something like 30% of sepsis cases, even after extensive testing, no specific organism is ever actually identified, which just highlights why it's so critical to start those broad-spectrum antibiotics empirically without waiting for culture results. You just can't afford to wait. All right, we've identified the enemy, some common entry points. Now let's dive deeper. Let's go inside the body itself. Witness this chaotic, almost self-destructive battle of sepsis unfolding. This is where that dysregulated response really shows its power.
It really is a complex and frankly terrifying interplay. You've got the invading pathogen interacting with the host's immune system, the coagulation system gets involved, and then there are the body's own desperate attempts to compensate physiologically and metabolically. The initial alarm bells we talked about, they're triggered by things called PAMPs, that stands for pathogen-associated molecular patterns, basically bits of the microbe, and also DAMPs, damage-associated molecular patterns, which come from your own cells when they get injured.
And those alarm bells, they unleash this flood of biochemical messengers, cytokines, mediators, kicking off an uncontrolled immune response. It sounds very much like acute inflammation, doesn't it? With those classic 5 signs we learned: rubor, redness, tumors, swelling, carrion, sweet dolor, pain, and functiolasa, loss of function.
It does, and that actually brings us back perfectly to that question you posed earlier. Can a patient have SIRS without having sepsis? And the answer definitively is yes. Remember, SIRS is that general alarm. Severe trauma, bad burns, pancreatitis, even a big heart attack. They can all trigger SIRS because it's the body's non-specific way of reacting to a major insult. The absolute key distinction, the moment that alarm signifies sepsis, is when there's an underlying infection driving that SIRS response.
That's like a critical point to grasp for anyone starting out. So someone with severe pancreatitis might tick all the boxes for SIRS, but it isn't sepsis unless there's also an infection causing it. Making that distinction is vital for getting the diagnosis right.
Exactly. Now, thinking again about those 5 signs of acute inflammation: redness, swelling, heat, pain, loss of function. Here's another thought question for you. How might those signs actually manifest in a patient with early sepsis? And interestingly, which ones might become misleading or less obvious in the later, more severe stages? Keep that rattling around as we move into the next phase of this internal battle.
That question leads us perfectly into the hemodynamic storm. People often describe it as the leaky pipe and the pressure drop. Just a super quick refresher on blood pressure basics. BP equals cardiac output times systemic vascular resistance, or SVR, and cardiac output is heart rate times stroke volume. Essentially, blood needs to be pumped under enough pressure to make sure all our vital organs get the oxygen and nutrients they need. Perfusion is key.
Right. Now, in early sepsis, those pro-inflammatory cytokines, the friendly fire from the immune system we discussed, cause widespread vasodilation. Imagine all your blood vessels suddenly relaxing and widening. This causes a big drop in SVR, that systemic vascular resistance, and that in turn leads to a fall in blood pressure. But here's the fascinating and potentially misleading part. This vasodilation can actually make the patient's skin, the peripheries, feel quite warm to the touch. We often call this early phase warm shock.
And that directly answers our question about the signs of inflammation. That widespread vasodilation, which is the body trying to rush immune cells to the site, can cause that calor or heat in the extremities, even though critically the vital organs might be struggling for perfusion. So it's a really deceptive sign of how sick the patient actually is.
Precisely. The body doesn't just sit there, though. The emergency crew immediately jumps into action, trying to compensate. You'll typically see the heart rate shoot up, the heart tries to pump harder, increasing stroke volume, and there's an attempt to constrict blood vessels elsewhere to increase SVR again. This is driven by the sympathetic nervous system adrenaline, noradrenaline, and hormones like cortisol, ADH, and the RAAS system kicking in. But often, these compensatory mechanisms just can't keep pace with the underlying problem.
And that's often when the capillary leak syndrome really takes hold, isn't it? Those same inflammatory cytokines start damaging the lining of the blood vessels, the endothelium. It's like the vessels become leaky, developing tiny holes. Fluid starts seeping out of the bloodstream and into the surrounding tissues. This leads to what we call intravascular hypovolemia, less fluid volume inside the blood vessels, which further worsens blood pressure, and it also causes that widespread tissue swelling or edema.
Yeah, and the heart gets hit too. Initially, you might see what's called a hyperdynamic circulation, where the cardiac output actually increases as the heart tries really hard to compensate. But that very fast heart rate means there's less time for the heart to fill between beats, which is diastole. This actually reduces the blood supply to the heart muscle itself through the coronary arteries. Combine that with the direct negative effects of cytokines, lack of oxygen, hypoxia, and acidosis on the heart muscle. Eventually, the heart muscle weakens, myocardial contractility becomes impaired, and cardiac output starts to fall.
Which brings us to that really critical distinction between compensated and decompensated shock. In compensated shock, the body is still, just about, managing to maintain a relatively normal blood pressure, even though all this chaos is happening underneath. This is your absolute golden window. This is when you need to recognize it and treat aggressively. Treat now. Because decompensated shock is when the blood pressure finally drops, the compensation fails, and it becomes much, much harder to pull the patient back. You really want to intervene before you reach that stage.
Absolutely. And this whole systemic mess, the poor perfusion, the leaky vessels, the struggling heart, leads to this devastating domino effect on all the vital organs. They suffer from reduced perfusion, lack of oxygen, ischemia and hypoxia, and ultimately dysfunction. Take the lungs. The body's metabolic demand goes up, so breathing rate increases tachypnoea. Fluid leaking into the lungs causes pulmonary edema. This can progress to acute respiratory distress syndrome, ARDS, which is severe respiratory failure causing profound hypoxia.
And in the tissues themselves, that lack of oxygen, the ischemia and hypoxia, forces the cells to switch to anaerobic respiration. This is way less efficient at producing energy, ATP. So cells start to malfunction. And a major byproduct is lactic acid. This buildup causes metabolic acidosis, specifically lactic acidosis, which is exactly why measuring lactate is so vital in sepsis. A high lactate level is basically shouting, my tissues are starving for oxygen.
Precisely. Then the kidneys. They're really sensitive to blood flow. Reduced blood volume, low blood pressure means reduced renal blood flow. This leads directly to acute kidney injury or acute renal failure. And the classic sign, reduced urine output. You absolutely have to monitor that urine output closely.
And the brain, our control center. It's incredibly dependent on a constant supply of oxygen and glucose and a stable pH. If any of that is compromised, you'll see changes. Confusion, An altered level of consciousness, which we often assess using scales like AVPU, alert, voice, pain, unresponsive, or GCS, Glasgow Coma Scale, lethargy, maybe irritability, especially in children. Changes in mental state are often one of the earliest and clearest signs of how unwell a patient truly is. And sadly, long-term neurological problems after sepsis are quite common.
And finally, let's not forget the coagulation system. It can go completely haywire in a condition called disseminated intravascular coagulation, or DIC. Remember that LPS from gram-negatives? That, along with the pro-inflammatory cytokines, triggers widespread clotting throughout the body's small blood vessels. Think of it like a massive traffic jam of tiny clots forming everywhere, blocking blood flow. But here's the terrible paradox. This massive clotting process uses up all the clotting factors and platelets faster than the body can make them. So after this initial clotting phase, you get depletion, and the patient develops a tendency to bleed uncontrollably. So you have this awful situation of clotting and bleeding happening at the same time. You might see visible signs like purpura, those small, non-blanching purple spots on the skin. It's like a bridge collapsing while traffic is still trying to drive over it. Utter chaos.
Wow, what a profound and frankly terrifying cascade of events. Understanding that pathophysiology, though, it's like our compass, isn't it? It guides us in how to recognize sepsis and how to treat it effectively. So with all that internal chaos happening, what does sepsis actually look like from the outside? What are the key clinical features we need to be able to spot?
Well, many patients will present with those fairly general symptoms, fever, maybe shivers or rigors, headaches, muscle aches, things you might associate with flu. But really crucially, you'll often hear the patient themselves or maybe their family say something like, they just feel really unwell, or they're just not their usual self. That subtle sense that something is fundamentally wrong, even if you can't quite put your finger on it, that's a massive red flag. It should immediately raise your suspicion for sepsis.
Right. Other signs to look for include things like loss of appetite, perhaps nausea or vomiting, maybe diarrhea. Rapid breathing is very common. And skin changes. The skin might be flushed and warm initially, as we discussed, or later it could be cool or cold, especially the hands and feet. You might see mottling, which is a sort of patchy, blotchy discoloration or pallor paleness. And definitely look out for any non-blanching rash like petechiae, tiny pinprick spots, or the larger purpura we mentioned. Any alteration in consciousness, irritability, lethargy, confusion, even convulsions or that reduced urine output we talked about, these are all immediate red flags.
And it's absolutely vital to always keep those vulnerable populations in mind. Your index of suspicion needs to be particularly high with these groups. We mentioned the immunocompromised, the very young, the elderly, also pregnant or recently postpartum women, postoperative patients, people with chronic diseases like diabetes or sickle cell. Anyone with an indwelling line or catheter, they might not present with the classic signs.
Okay, so when you approach a patient you suspect might have sepsis, how do you assess them systematically?
You always fall back on the structured ABCD approach. It keeps you focused and ensures you don't miss anything critical. A is for airway. First, is it open and clear? Can the patient maintain it? B is for breathing. Check their respiratory rate. How fast are they breathing? Check their oxygen saturations. Are they hypoxic? Listen to their chest. C is for circulation. Feel their pulse. Is it fast? Tachycardia. Check their blood pressure. Is it low? Check capillary refill time. How quickly does color return after pressing on the skin? Look at the peripheries. Are they warm or cold? D is for disability. Assess their neurological status. Level of consciousness using AVPU or GCS. Check their pupils. And critically, check their blood glucose. Hypoglycemia can mimic sepsis symptoms. Also, monitor that urine output. It's a key indicator of kidney perfusion, which falls under disability exposure. And E is for exposure. You need to fully expose the patient while maintaining dignity to do a proper head-to-toe examination. Look for the source of infection rashes, wounds, cellulitis, check lines, and measure their temperature.
That's a great systematic approach.
Yeah.
You mentioned investigations there. Any quick anchor or mnemonic for the immediate test?
Yeah, a useful little mantra to keep in your head for those immediate critical investigations is don't ever forget glucose, ABG, lactate, bloods, cultures. So check the glucose. Get an arterial or venous blood gas that gives you pH, oxygen, CO2, bicarbonate, and often lactate. Send off routine bloods like full blood count, FBC, urea and electrolytes, UNEs, liver function tests, LFTs, C-reactive protein, CRP, and a clotting screen. And crucially, get those cultures, blood cultures from at least 2 different sites, plus urine, sputum, wound swabs, whatever seems relevant to find the source.
That's really helpful. Don't ever forget glucose, ABG, lactate, bloods, cultures.
Got it. Now, another really vital point you touched on earlier, fever isn't always present, is it? No, absolutely not. And this can really catch people out. Patients, particularly the elderly, sometimes cancer patients on treatment, very young infants, or even people with spinal cord injuries, they might actually present with hypothermia, a low temperature, or even a completely normal temperature. So please, never let the absence of a fever falsely reassure you if the rest of the clinical picture looks worrying. Think sepsis anyway.
Okay, this brings us neatly to the early warning systems that hospitals use. These are like our radar systems for spotting deterioration and potential sepsis, right? The NWS2 score is commonly used.
Yes, the National Early Warning Score 2, NWS2, is a fantastic tool. It's widely implemented. It scores points based on 6 key physiological parameters: respiratory rate, oxygen saturations, whether they need supplemental oxygen, pulse rate, blood pressure, systolic, temperature, and level of consciousness, usually using AVPU. The total score helps stratify the patient's risk pretty quickly.
How does the scoring generally work?
So a score of 0 is very low risk. 1 to 4 is considered low risk, but still needs regular monitoring. A score of 5 or 6 indicates moderate risk and requires more frequent observation and usually escalation to a more senior clinician. And a score of 7 or more signifies higher risk of severe illness or death, demanding urgent review by a senior doctor or a critical care outreach team. And there's a crucial detail. If any single parameter scores a maximum of 3 points, for example, a very high respiratory rate or very low blood pressure, that automatically triggers a high-priority clinical review, regardless of the total score. It flags up extreme abnormality in one system.
That makes sense. And beyond the score itself, are there other immediate red flags we should look for, even if the NWS2 isn't sky high?
Absolutely. Certain clinical signs are immediate stop everything and act signals. A non-blanching rash, petechiae or purpura that suggests possible meningococcal disease or severe DIC, a mottled or ashen appearance to the skin, central cyanosis, blue looks, or tongue. These are immediate red flags requiring urgent intervention, irrespective of the new WS2 score.
Got it. What about outside the hospital setting, like in primary care or the emergency department triage? Is there a quicker tool?
Yes, for a really rapid triage, especially in non-ICU settings, the qSOFA score qSOFA can be useful. SOFA stands for Sequential Organ Failure Assessment. qSOFA is simpler, just looking at 3 criteria, each scoring 1 point if present. 1, a low systolic blood pressure, defined as 100 millimolars G or less. 2, a high respiratory rate, 22 breaths per minute or more. And 3, altered mentation, which usually means a Glasgow Coma Scale score of 14 or less. A qSOFA score of 2 or more suggests a higher likelihood of poor outcomes associated with sepsis and warrants further investigation and potential escalation of care.
It's a quick bedside prompt.
Yep.
And you also mentioned a simple sepsis screening tool earlier.
Yeah, many hospitals or guidelines use a very simple screening tool, often based around 4 key questions that clinicians should ask themselves. Question 1, does the patient look unwell, or do they have abnormal vital signs, like those in new WS2? Question 2, could this illness be due to an infection? Is there a potential source? Question 3, are any specific sepsis red flags present? These often include things like the low BP, high lactate, non-blanching rash, reduced urine output, altered consciousness. Question 4, if no red flags, are any sepsis amber flags present? These are slightly less severe signs but still warrant concern and investigation, like tachycardia, tachypnea, recent trauma surgery, or feeling generally very unwell. It just helps structure the thinking process.
And the investigations we mentioned, blood gas with lactate cultures, FBC, CRP, UNEs, LFTs, clotting, they all fit in here to confirm the diagnosis and guide the treatment, right?
Right.
Along with imaging like chest x-rays if needed.
Exactly. They're all pieces of the puzzle to confirm sepsis, assess severity, identify the source, and monitor the response to treatment.
Okay, so you've used your clinical skills, the warning scores, the screening tools. You suspect sepsis, the alarm bells are ringing loud and clear. Now what? Now it's time to fight back. This is where the Sepsis 6 comes into play. It's described as this rapid response toolkit, a bundle of interventions that absolutely must be initiated within the golden hour, that first hour after recognition. The key insight seems to be doing these 6 things together almost simultaneously, gives the patient the best possible chance of stopping that downward spiral.
Absolutely. Time is critical. Time is tissue, time is organ function, time is life in sepsis. These are the Sepsis 6, usually remembered in 2 groups of 3 give and 3 take actions. First, the give-E bundle. 1, give oxygen, deliver high-flow oxygen immediately. Aim to keep oxygen saturations above 94%, or 88-92% in patients at risk of CO2 retention, but still give oxygen. Get that oxygen to the starving tissues. 2. Give IV antibiotics. Administer broad-spectrum intravenous antibiotics as soon as possible, ideally within that first hour. Check for allergies first. Don't delay for cultures if the patient is critically ill. Every hour delay increases mortality significantly. Start empirically based on likely source, then tailor later if possible. 3. Give IV fluids. Start intravenous fluid resuscitation promptly, usually with crystalloids like 0.9% saline. Give a bolus, like 500 milliliters over 15 minutes. Then reassess hemodynamics, lactate urine output. Repeat if needed, but be careful not to fluid overload. This counters the vasodilation and capillary leak.
Okay, oxygen, antibiotics, fluids. The give 3. What are the take 3?
The take bundle. 4. Take blood cultures. This is crucial before giving antibiotics, if possible, without causing significant delay. Get at least 2 sets from different sites. Identifying the specific bug and its sensitivities is key for targeted therapy later. 5. Take lactate. Measure the blood lactate level. As we discussed, it's a vital indicator of tissue hypoperfusion and how sick the patient is. A falling lactate suggests treatment is working, usually done via a blood gas sample, ABG or VBG. 6. Take urine output measurement. Start accurately monitoring urine output, usually by inserting a urinary catheter. It's one of the best indicators of kidney perfusion and fluid balance adequacy. Aim for more than 0.5 milliliters per kilogram per hour.
Oxygen, antibiotics, fluids, cultures, lactate urine output, the sepsis 6. 6 critical actions within 1 hour. It sounds like a powerful intervention bundle.
It really is. Implementing the sepsis 6 reliably and rapidly has been shown to significantly improve outcomes.
And beyond the sepsis 6, obviously other supportive care is vital too.
Of course. Depending on the severity, you might need to ensure the airway is protected, perhaps requiring intubation and mechanical ventilation. If fluids alone aren't enough to restore blood pressure, the patient might need vasoactive drugs like noradrenaline, inotropes, or vasopressors, usually in an intensive care setting. You need ongoing monitoring of their neurology, GCS, acid-base status, electrolytes, blood sugar, treat hypo or hyperglycemia, manage pain effectively, keep the patient and their family informed about what's happening. And depending on the bug, you might need to inform public health authorities. It's a multidisciplinary effort, really. Every aspect of supportive care contributes to turning the tide against sepsis.
We've covered the intense immediate battle, but the fight against sepsis, unfortunately, doesn't always end when the patient leaves the hospital, does it? For many survivors, the impact can cast a really long shadow.
It really can. Sadly, despite our best efforts, some patients still die from sepsis. But even for survivors, the complications can be significant and long-lasting. They might be left with chronic organ dysfunction, impaired lung function, heart problems, chronic kidney disease, liver issues. Some patients require amputations due to poor peripheral perfusion or DIC. Malnutrition is common during critical illness. Sepsis can also cause profound immunosuppression, making survivors vulnerable to other infections or reactivating dormant viruses like herpes simplex, HSV, or varicella zoster, VZV, which causes shingles.
And there are other consequences too, right? Like hospital-acquired infections during their stay?
Yes, that's a risk. And then there are the less visible but equally devastating long-term consequences. Significant neurological problems are common difficulties with concentration, memory problems, sometimes called brain fog, or cognitive impairment. Many survivors experience post-traumatic stress disorder, PTSD, related to their critical illness experience. Chronic pain and debilitating chronic fatigue are also frequently reported. The overall impact on quality of life can be absolutely immense. It's a constant reminder of the battle their body went through.
It really underscores why prevention and early recognition are so incredibly important. What are the key preventative strategies?
Well, some infections that can lead to sepsis are vaccine-preventable things like pneumococcus, Haemophilus influenza type B, HIB, meningococcus influenza. So vaccination programs are crucial. Basic hygiene, both personal and in healthcare settings, is fundamental. Strict aseptic technique when inserting and managing intravenous lines, urinary catheters, and during surgical procedures is vital to prevent healthcare-associated infections. But beyond that, it comes back to maintaining that high index of suspicion we've talked about. Recognizing sepsis early and intervening rapidly is, in itself, a form of secondary prevention, preventing progression to severe sepsis and shock.
And recognizing those at-risk groups we discussed earlier.
Exactly. Being extra vigilant with vulnerable patients, employing contact tracing for certain infectious diseases like meningococcal disease to prevent spread, and, critically, practicing good antibiotic stewardship using antibiotics appropriately only when needed, choosing the right drug, dose, and duration. This helps prevent the development of antibiotic resistance, which makes sepsis even harder to treat. But perhaps the single most important preventative measure for any clinician is the mental one. The constant reminder, the mantra, must always be, think sepsis.
That's a powerful takeaway. Think sepsis.
Ah,
So we've covered a huge amount today on our deep dive into the complex, dangerous world of sepsis. We went from understanding its core definition, that life-threatening organ dysfunction caused by a dysregulated host response to infection. We explored the devastating pathophysiology, the cascade of inflammation, hemodynamic collapse, and organ failure. We looked at how to recognize it using clinical signs, warning scores like new WS2, and crucial investigations. And we emphasized the absolute urgency of management with the Life-Saving Sepsis 6 bundle.
yeah, I think the key message is clear. Sepsis is a time-critical medical emergency. Every minute truly does count. Your ability as a developing clinician to consistently think sepsis, to spot those often subtle signs early, and to initiate those crucial Sepsis 6 interventions without delay. That can genuinely be the difference between recovery and devastating lifelong consequences, or even death.
It really drives home the responsibility. And as you continue in your medical career, here's maybe a final provocative thought to mull over. Sepsis really throws into sharp relief that double-edged sword nature of our own immune system. It's meticulously designed to protect us, yet in this condition it turns inward, causing catastrophic harm. How might that fundamental understanding that the body's own defenses can become the threat shape your approach, not just to sepsis, but perhaps to other conditions too, like autoimmune diseases or severe allergic reactions? It's a question that really challenges us to always look at the bigger picture, the host response, not just the initial trigger. Keep learning, keep questioning, keep thinking critically, and always, always remember to think sepsis.